you all for this virtual postgraduate API-ICP training program. We have with this week Dr. Ramasamy sir, the Assistant Professor of Cardiology Department. Thank you, sir, for being the faculty today and to guide the students regarding the approach towards the valvular heart disease. Today's topic, and we are going to expect the head of the department and Professor of Cardiology, Dr. Tamil sir, going to join soon. Really, thank you, Dr. Tamil, for this joining us today evening. And we have with us the Department of Medicine, the final year postgraduate Dr. Vinod Pandey is going to present the case on approach towards a patient with valvular heart disease. Over to Dr. Ramasamy sir and Tamil and Vinod Pandey to take over the further proceedings of this session. Over to you.
Thank you.
Pandey, start presenting.
Good evening, sir. Shall I start, sir?
Yeah, please.
Good evening, one and all. Today we are going to see the approach to the valvular heart disease. A 27-year-old female residing at E Road and a homemaker by occupation came with the chief complaints of breathlessness on exertion for the past 2 years, palpitation for the past 2 years, and fever with cough and expectoration for the past 1 week. History of presenting illness. Patient was apparently asymptomatic 2 years back, following which she developed breathlessness on exertion, which was gradual in onset, progressive in nature, progressed from NIHA class 2 to class 3, which was more for the last 1 week, which is aggravated by exertion, relieved by taking rest, no seasonal variation. No history of orthopnea or paroxysmal nocturnal dyspnea. History of palpitation for the past 2 years, which is insidious in onset and intermittent, which is fast and regular, noticed on exertion, relieved by taking rest, not associated with giddiness, syncope, sweating, chest pain, or post-palpitation diuresis. No history of palpitation at rest.
The palpitation brought on exertion.
Yes, sir.
How long it does it last?
It's for the 2 years, sir, but it's during only exertion only it is persisting.
It gets relieved by rest.
Yes, sir. Getting relieved by rest.
So, how can you approach palpitation as such? Suppose the patient comes with a palpitation. What are the leading questions you try to put and to get this an idea what type of arrhythmias he is suffering from, he is having?
It's maybe regular or irregular palpitations, sir.
First, whether it is a regular, first of all, it is age. See, if the younger individual comes with recurrent palpitation, it's likely to be SVT. If the elderly people after 40, 50 years comes with recurrent palpitation, it goes in favor of ventricular arrhythmia. So, depend upon the age, either we can think of ventricular arrhythmias or atrial arrhythmias. The younger individual, predominantly it is atrial arrhythmias. If it is elderly individual, it's likely to be a ventricular arrhythmia. Second thing, if it is a recurrent, does not associated with any LOC, loss of consciousness, seizure, it's atrial arrhythmias. If the patient has any loss of consciousness and seizure, it leads to ventricular arrhythmias like ventricular tachycardia and ventricular fibrillation. Okay, this is a way to approach. So again, arrhythmia, if it occurs at rest, likely the palpitation occurs at rest, likely arrhythmia. If it is a brought on exertion, then it is a disease related.
Okay.
So what do you think? Do you think it is a disease related palpitation or arrhythmia?
It's a disease related, sir.
Hope you are able to follow me.
Yes, sir. It's disease related palpitation, most probably.
Okay.
Hello.
The second thing is it there is no seasonal variation. What was your mind when you asked for seasonal variation?
Bronchitis.
Bronchitis?
Asthma.
So seasonal bronchitis, you mean asthma, you kept in the mind of respiratory disease.
Yes.
That can go in that varies in season, isn't it? That's what you meant.
Yes, sir.
Okay, go ahead. How long it took for the patient to go for a class 3 dyspnea from class 2?
From class 2 to class 3. She has become class 3 since last 8 months, sir.
So 2 years she remains in static class 2.
Yes, sir.
Only 2 weeks ago she has developed class 3.
Yes, sir.
Okay. What do you think? What precipitated what worsened the NHA class from class 2 to class?
Cardiac or non-cardiac causes, sir.
Very good, very nice. What are the non-cardiac causes you anticipate? What are the non-cardiac causes you will expect?
Non-cardiac causes like any hyperdynamic circulation states and fever, uh, thyroid illness.
Very good. All non-cardiac circulation, fever, periphery, anemia, pregnancy, all these things can worsen the conditions. Okay, cardiac wise.
Cardiac wise, any arrhythmias, any disease progression itself may cause.
Okay. So not only disease progression, arrhythmias, and reactivation of the rheumatic fever or infected carditis. So these are infection, progression of the disease, reactivation of rheumatic fever. All these things can worsen the pre-existing NLC class. Okay.
Yes.
So which one fits in this patient? Is it a reactivation of the rheumatic fever? Is it a disease progression, or it is infection, or it is non-cardiac cause like epidemic circulation?
Recent worsening may be due to the fever, sir.
Fever. So fever can be even a rheumatic reactivation can have fever, isn't it?
Yes, sir.
Infected carditis can have fever.
Disease progression itself may cause, sir, from 2 years to progress to the class 3.
Yeah, there's a this one reasonable this one explanation. Okay. Yeah, go ahead.
History of fever for the past 1 week, which is low grade, intermittent, not associated with the chills or rigor, relieved by taking medications. History of cough with expectoration for the past 1 week, which is insidious in onset, progressive in nature, no postural or diurnal variation, no aggravating or relieving factors. Sputum, which is yellowish in color, and sir.
Do you know what diurnal variation you like, sir?
It's nighttime. During nighttime, cough may be aggravated, sir, in heart failures.
No, it's not so. Anybody who has got cough on lying posture is equivalent to orthopnea. Okay, remember that. If somebody has a cough, dry cough, while immediately after lying down, this should be interpreted as the orthopnea equivalent. Okay, not night cough. Cough can come anytime. Whenever he lies down, because of the pulmonary congestion can have. So anybody who gets a dry cough immediately after lying down, this should be taken as a orthopnea equivalent. Okay. Are you able to follow me?
Yes, sir.
Yeah.
Sputum, which is yellowish in color, mucoid in consistency, not blood tinged, no foul smelling, no postural or diurnal variations.
Okay.
No history of chest pain or syncope, no history of leg swelling, facial puffiness or abdominal distension, no history of bluish discoloration of skin or mucous membrane, no history of recurrent respiratory tract infection in the childhood, or a cyanotic spell or a squatting after the exertion, no history of wheezing, no history of hoarseness of voice, hemoptysis or dysphagia, no history of weight loss or weight gain, no history of sore throat or involuntary limb movements, no history of any no history of any urinary disturbances or reduced urine output, no history of rashes, myalgia or joint pain, no history of abdominal pain, vomiting or loose stools, no history of headache or altered sense.
You don't get any urinary disturbance in the cardiovascular disease. Only as far as the sphincter incontinence is concerned, the patient has got overdiuresis, the urine output may come down. If somebody has oliguria in the daytime and polyuria in the night time, it indicates congestive cardiac failure, because during congestive cardiac failure, patient lies down in the night due to reabsorption of the edematous fluid, the intravascular volume increases, so it causes polyuria. If somebody has a frequently go to the restroom in the night time and has hardly passing urine in the daytime, it's a feature of congestive cardiac failure. Otherwise, urinary disturbance will do with the heart cardiac disease.
Okay.
Yeah. Anything else? So there are other things you asked about this one. There's some bluish discoloration.
Yes, sir.
What cardiovascular disease? What is in your mind?
Any cyanotic congenital heart diseases.
Okay, go ahead.
Okay. Past history. No history of similar complaints in the past. Patient was on evaluation for the infertility for the past 8 months. During the evaluation, she was informed that her echo showed some cardiac abnormality. Currently on oral contraceptive pills for the menstrual irregularity. No history suggestive of rheumatic fever. No history of diabetes mellitus, systemic hypertension, bronchial asthma, COPD, ischemic heart disease, or tuberculosis. No previous history of any surgery or dental procedures.
Is a primary infertility or secondary infertility?
So primary infertility.
Any cardiac disease is associated with infertility? What is
probably a Turner syndrome.
Turner syndrome, okay.
Coarctation of aorta.
Coarctation of aorta, why should have infertility? Does it interfere with the gonadal arteries? What is cardiac syndrome?
It's situs inversus and asuspermius.
Another cardiac problem?
Situs inversus.
Okay,
ciliary
immobility. That can cause azoospermia. So people have a cardiac syndrome can have a infertility, cardiac disease as well as infertility. Okay.
Yes.
Right. OCP, any cardiac disease, OCP can what cardiac disease can cause?
Oral pills can cause pulmonary thromboembolism, sir.
So it can cause a DVT, pulmonary embolism, it can cause volume fluid retention, it can cause
fluid retention, hypertension.
Okay, these are all the things one has to keep in mind. Okay, but I remember one famous cardiologist who happened to see his wife, my friend's wife, missed a DVT because he forgot. He fails to ask OCP history. Then he regretted after she died. Okay, so OCP can be very notorious drug as far as cardiovascular disease is concerned. Not only DVT but also hypertension and other things. Okay.
Okay.
Right. Yeah, go ahead.
Family history. A patient born out of non-consanguineous marriage. No history of cardiac disease in the family. No history of sudden cardiac death. And this is the pedigree chart, sir.
Okay.
Menstrual history. Menarche attained at the 13 years of...
I'm not able to see your slides, Pa. Your only name, serious case presentation, Dr. Vinod Pandey, postgraduate. There's only one slide is being displayed. Oh, yeah, now we can see. Yeah. Okay.
Okay.
When you ask for a sudden cardiac death, what is your mind? What cardiac disease you kept in your mind?
HOCM, sir.
Yeah, very good. HOCM. Broda syndrome, HOCM. All these things can run in the family. Yeah.
Menstrual history. Menarche attained at 13 years of age. And she has irregular periods once in 45 days, lasting for 4 to 5 days. She is changing 5 to 6 pads per day. Personal history. She's
cardiac disease and cardiac medication. This causes interfere with the menstruation. You are dealing with rheumatic heart disease, isn't it?
Yes, sir.
So the patient takes oral, is an anticoagulation. You don't have more plates. You can instead of other women compared with other women, she may use more pads because of the oral anticoagulation effect. Okay.
Oh.
Right. I'm going to ask you in exam. You should be ready with the answer because you said how many pads will change per day, isn't it?
Yes,
then the next question will ask you what way the cardiovascular disease concerned with interfere with the menstruation. You should be ready with, if the patient is in fibrillation, has got anticoagulation, then she's tend to have a menorrhagia, isn't it?
Yes. Yes. Yeah. Personal history. A patient was on a mixed diet, normal bowel and bladder habits, normal appetite, normal sleep pattern, no history of any drug or food allergy, married since 7 years. Summary. This is a 27-year-old female with no known comorbidities on oral contraceptive pills for the irregular menstrual periods and presented with progressive exertional breathlessness and palpitation for the past 2 years with recent worsening of the symptoms, now presented with 1 week history of low-grade fever and productive cough. My probable system involved is cardiovascular system, sir, with the recent worsening due to respiratory system infections.
Join பண்ணிங்களா? Okay. Yeah, correct. So with this summary, okay, very nice. Presentation is the very meticulous. I won't find any fault on your presentation so far. So what's your this interpretation, conclusion based on the present history and the past history? Do you think the patient is suffering from congenital heart disease? This is a way of approach. First, you have to see whether it is a congenital or acquired. Then, if it is a congenital, whether it is acyanotic or cyanotic. If it is a cyanotic, then it is increased pulmonary blood flow or decreased pulmonary blood flow. Okay. Now, is it a congenital or acquired?
It's most probably acquired heart disease.
It's also acquired. Okay.
Yes, sir.
So can have some congenital heart disease which getting worsened.
It's VST can have, sir, atrial septal defect.
But you said no. You said patient did not have any recurrent respiratory infection, so that rules out any shunt lesion.
Yes, sir.
Isn't it?
Congenital mitral stenosis may be there.
Congenital mitral stenosis, it cannot progress from class 2 to class 3 in 2 years, no? So the patient has got a mitral prolapse. It's more common in women. Okay. Right. So that can go for a sudden cardiac rupture, which can worsen the symptom and existing
heart
energy class. Okay. Right. Any sinus valve rupture?
Rupture sinus.
It's more common in young adult, but this hard and fast should not happen in a later women also. Okay. So these are a few congenital heart disease can present suddenly worsening in a few weeks. Okay. Okay. So tell me, all heart disease acquired is a left-sided or right-sided?
Probably a left-sided valve involvement, sir. Most probably a mitral and regurgitant more than a stenotic lesions.
So what do you think it's a regurgitant lesion first? Why not stenotic?
Sir?
What made you to think of regurgitant lesion rather than stenotic?
Palpitation is more common in regurgitation, sir, than stenotic lesions, sir.
Yeah, the regurgitant lesions tend to present with initial presentation tend to be palpitation, whereas the syncope and dyspnea is tend to be the initial presentation with the
stenotic
lesions. That's why you thought. So okay, right? It's a sound thinking, logical thinking, I would say. So whether it is, you said, is the left-sided, isn't it?
Yes, sir.
So now whether there are two valves in the left-sided, whether it is in the mitral regurgitation or aortic regurgitation. So historically, could you make out anything, any clue we can get from history alone? Forget about that. We have not gone to the general examination. We are at that stage of presenting illness, past history, family history, and personal history, isn't it? So based on that, this available information from the patient, can you get a clue whether it is a mitral or aortic? How to go about it?
Chest pain, sir.
The patient has got a palpitation, dyspnea. It goes in favor of
mitral.
The patient has got a nocturnal angina and syncope, then it goes in favor of
aortic.
Because in a mitral regurgitation, early it gets dilated. So a patient may develop atrial fibrillation, easily going for a pulmonary congestion. So PND, orthopnea, recurrent palpitation is favors mitral, whereas nocturnal angina, nocturnal angina, dyspnea and exertion, these are the favors aortic. Okay. So we can get to some extent we can guess whether it is mitral valve involved or aortic valve involved. Right?
Okay.
So most probably it's a mitral or aortic. What do you think now?
It's mostly a mitral valve involvement.
Very good. It's a mitral valve. So it doesn't have any nocturnal angina and no this one. Now the things is favors syncope and other things are not present, so the aortic valve involvement is less likely,
Okay.
right?
Yes, sir.
Right. So keeping it in mind, left-sided acquired valvular heart disease, likely a regurgitation at the mitral valve level. We'll proceed to the general examination.
Yes. On examination, patient was conscious, cooperative, comfortable at rest, afebrile, no pallor, icterus cyanosis, clumping, lymphadenopathy or pedal edema. JVP not elevated, abdominojugular reflex is normal. Fundus examination and thyroid examination was normal. No markers of congenital heart disease, infective endocarditis, rheumatic fever or atherosclerosis. Oral cavity examination is normal.
And we said no markers of rheumatic fever. What rheumatic fever markers did you look for?
And erythema marginatum, subcutaneous nodules.
Yeah, erythema marginatum is rarely seen in Indian scenario, so better not to commit an exam because we are all black-colored people. Erythema marginatum is seldom, very difficult to make out in our skin color. But you can look for a subcutaneous nodules in this occipital and external aspect of the arm. Okay. Then of course, so otherwise this erythema marginatum last only very short period. It's very difficult to make out in our population, right? You better not to commit an examination.
Okay, sir. Okay.
Yeah. Markers of infective endocarditis.
Infective endocarditis, I can see Janway lesions and hot spots.
Subconjugal hemorrhage. Okay.
Subconjugal hemorrhage, sphincter hemorrhage.
Okay, fine. What you are having a valvular heart disease, you said mitral valve is involved in the form of regurgitation. What congenital deformity you will look for if the patient has got a mitral regurgitation? Is my question clear?
Marfan syndrome.
Very good. So Marfan syndrome. So when you are expecting anticipating a mitral valve regurgitation, should look for a features of Marfan syndrome. This is a tall stature, long arm span, okay. So thin built. These are all the wrist sign, thumb sign. All these things are present or not. Okay. These are the markers of congenital heart disease as far as the mitral regurgitation is concerned. Okay.
Okay.
Vinod?
Sir?
Vinod?
Yeah,
Sir. Good evening, Vinod. Sorry for late joining, some commitments.
Okay.
What is the criteria to diagnose Marfan? That you say a Marfan, we can't say by blindly with a few findings. There should be a criteria. Do you have any name criteria to diagnose Marfans?
Kent, sir. Kent.
Fantastic. Very good. Excellent. Modified Kent. It's called modified. You want to, any idea about how to categorize or diagnose with Kent criteria?
The family history, sir.
Fantastic. Family history and without family history. Categories two groups. Family with family history, without family history. And with, I said, okay, you read that. Okay, that should be, in few exams, and as we'll ask these questions, just read. Okay.
Okay.
Fine. Please proceed.
Okay. Vitals, BP 90/60 mm of HC in the both upper limbs at a supine posture, and 84 systolic in both lower limbs. Pulse 80 per minute, regular in rhythm, normal in volume, no specific character. Condition of the vessel wall is normal, no radio or no radiofemoral delay. All peripheral pulses are felt. Respiratory rate is 18 per minute. Thoraco-abdominal, no usage of accessory muscles of respiration. SpO2 is 98% in room air. Temperature is 98 Fahrenheit.
So, with the general examination, what is your conclusion? Is there anything adds along with your history?
From the BP, we can rule out the regurgitant lesions.
Oh, fine, fantastic. So your regurgitant lesion is low probability or nil. Okay.
Yes.
So next.
Very good. It's correct because pulse pressure is not so wide, so they straight away roads out aortic regurgitation. Okay.
Yes, sir. Measurements: height is 164 centimeter, arm span is 162 centimeter, weight is 58 kg, BMI is 21.6. Upper segment is 80 centimeter, lower segment is 86 centimeter, and the ratio is 0.9. Height neck ratio is 12.6.
Normal, no?
Yes, sir, normal, sir. Less than 13 point.
Fine, fine.
CVS examination propers. On inspection, chest wall is bilaterally symmetrical, moves equal with respiration, no deformity. Trachea appears to be in the midline. Apical impulse not visible, no precardial bulge, no visible scars, sinuses, pulsations, or dilated veins over the chest or back, no spine deformities.
Okay, fine.
Palpation, tracheal position confirmed by the palpation. Apical impulse felt in the left fifth intercostal space, 1 centimeter medial to the midclavicular line, which is tapping in character and no thrill. No left parasternal heave, no epigastric pulsation, no palpable heart sounds or carotid thrill.
Okay, go ahead. Yeah.
Sir?
Yes, yeah.
Proceed, please.
On percussion, right cardiac border correspond to the right sternal border. Left cardiac border correspond to the apical impulse. Left second intercostal space is dullness present. Right second intercostal space is resonance.
What's interpretation here?
So probably a dilatation of pulmonary artery leads to pulmonary hypertension.
Good. So the right second intercostal space is dull, the aorta is dilated. If the left intercostal space, second intercostal space is dull, pulmonary is dilated. If the right cardiac border is extended, it's a right chamber dilatation. If the left side is extended, it's a LV dilatation or pericardial effusion. If it goes beyond that, it's a pericardial effusion or a LV enlargement. Okay. So here you have got a dullness in the left second intercostal space. Okay. So likely it indicates dilatation of the main pulmonary artery.
Okay. Yes.
Yeah, go ahead.
Okay. On auscultation, mitral area, first and second ultrasounds are heard. First ultrasound S1 is loud, no S3 or S4. Opening snap present. So low pitched, there is a low pitched rough rumbling, mid diastolic murmur with a pre-systolic accentuation of grade 3/4 in intensity in the mitral area without any radiation heard with the bell of the stethoscope. Best heard in the left lateral position at the height of the expirations.
Okay, fine.
Fine.
Next is a left lower sternal border. First and second ultrasound heard, no murmur or added sound. In neo-aortic area, first and second ultrasound heard, no murmur or added sound. In pulmonary area, and first and second ultrasound heard, loud P2 is here. Variable S2 split present during the inspiration, no murmur or added sound. Aortic area, first and second ultrasound heard, no murmur or added sound, and no carotid bruise.
You said variable S2 split. Huh?
Yes, sir.
The variable split is normally split, normal respective variation, or either it's a narrow split or either
normal split, sir, during inspiration.
Fine. It's a normal split, and it varies. Okay, fine. That's good. Fine.
The auscultation is an art. Vinod.
Sir.
It was as this one stressed upon by this one, Levin and Harvey, decade by many century ago. I should use two methods. One is inching method or selective listening. The inching method is you move the stethoscope inch by inch from one area to other area.
Yes, sir.
Okay. Another is selective listening. Selective listening is it's very difficult. One should not concentrate heart sounds as well as murmur simultaneously. Okay. First you concentrate first heart sound, then second heart sound, then concentrate only systolic event, then concentrate only diastolic event. You follow these two methods of inching and selective listening, the mistakes are very less likely takes place. Okay.
Okay.
Right. And
Okay.
remember, when the heart rate is very high, the systolic period remains normal. The diastolic period is shortened. The systolic period and diastolic period almost becomes equal when the heart rate is 120 to 130. So if the heart rate is very high, you can give a slight cardiac massage, cardiac massage, and break down the heart rate, then auscultate. If you do this, follow this, you will seldom will commit a mistake. Okay.
Okay, sir.
This is my advice for all postgraduates.
Okay.
Fringing method and selective listening. Okay.
Okay, sir.
Right.
Other systemic examination on respiratory system, bilateral normal vesicular breath sound is heard and no added sound. On parabdominal examination, soft, non-tender, no organomegaly. And central nervous system examination, GCS full and no focal neurological deficits. Probable diagnosis is probably acquired valvular heart disease of rheumatic etiology involving in the form of mitral stenosis, which is moderate to severe in severity. Patient in a regular rhythm with features of pulmonary hypertension without features of heart failure or infective endocarditis or acute rheumatic fever. Now patient on NIHA class 3, probably a febrile illness due to recent respiratory tract infections.
You go back to the previous slide, Oscar. Previous slide. Yeah. Next slide.
Yes, sir.
Yeah. You are not mentioned about ear to voice gap, no?
Okay.
Isn't it? So which are all the way the mitral stenosis can be assessed? Severity of the mitral stenosis, how do you assess?
A2OS gap and duration of the murmur, sir.
So it's important to mention about the
A2OS.
A2OS gap, isn't it?
Okay.
So both opening snap as well as the LVS3, both are diastolic event. Immediately takes place after second heart sound. How do you differentiate this to one from one another?
So S3 will be here as a S2 split, sir, in the mitral area. And opening snap will be here in the all the areas.
So S2 is yes, sir. Yeah, no, it's not S2, either S3.
S3
and opening snap will get confused, isn't it?
Yes, sir.
So how can you make out whether it is opening snap or LVS3?
It's here like a S2 split in the mitral area, sir. If it is here only in the mitral area, we can see it as a S3, sir.
Yeah, very good. If the S3 is always localized, the LV3 is localized to the mitral area, and the RVS3 is localized to tricuspid. It will not be heard other places. Whereas opening snap will be heard all over the pericardium. Okay. So that's relatively the opening snap is louder than S3. Okay. So both will resemble as second, like a second splitting of second heart sound. Okay. Yes. So this is the way you have to differentiate. Is right?
Yes, sir.
Will you expect a S3 here?
No, sir.
Yeah, very good. Why not?
Mitral stenosis.
When the mitral valve is stenosed, you cannot have a rapid filling. The rapid filling is literally absent in a mitral stenosis. So we cannot expect S3 in severe mitral stenosis. Okay. So you said severe mitral stenosis. Now, what are the points which favor mitral stenosis? Severe mitral stenosis, right from clinical exam, baby pulse, everything. What are things favors your severity?
Okay. Loud P2, sir, pulmonary hypertension features.
The loud P2 indicates the presence of loud P2 indicates patient has got a pulmonary hypertension. That's all. It does not help to quantify the severity of the MS. It may be severe, but it may be loud in a severe MS. But presence of loud P2 is not going to help you to say that the patient has got a severe MS.
Okay.
First of all, what are the features favors my MS right from the beginning?
So
Small volume pulse.
Small volume pulse.
Relatively narrow pulse pressure.
Narrow pulse pressure.
Tapping apical pulse.
Apical impulse in the left
Yeah.
fifth intercostal space, 1 centimeter medial to the mid-clavicular line. Tapping in character. And
the long run MDM plus pre-systolic.
Auscultation.
Okay.
Yes, sir.
Only thing, the port near to OS gaps should have been common. This mentioned. Send it.
Oh, yes, sir.
Tamil, you want to add something? Hello, Tamil.
Hello.
Yeah, you would like to add something? Anything?
Yes, sir. Sir, he said moderate to severe MS. Why you want to, Vinod? You said moderate to severe MS. Hello.
Hello, sir.
You said moderate to severe MS.
Yes, sir.
Why you want to say moderate, and why you want to say severe, or moderate to severe MS?
Patient does not show any RVH features, and probably that's leads to moderate in intensity.
Oh, if the patient is symptomatic MS, you have a PAH.
Yes, sir.
Clinical evidence of PAH is there, and patient is symptomatic. Do you think this is enough to say that? Plus, your clinical finding, long murmur, A2OS is narrow, what you say. Possibly, this is enough to say as a severe MS.
Yes, sir.
So, still you want to bring as a moderate, or you want to fix with severe?
Mostly, it's a severe MS. Yes.
Fine. What are the complications of MS where it doesn't depend upon the severity of mitral stenosis?
In fact, the question is, there are few things that are inversely proportional to the severity of the MS. Got my question? You know,
sir,
there are few things are not directly proportional to the disease.
Thrombus formation, atrial fibrillation, and infective endocarditis.
Very good, excellent. So, infective endocarditis, atrial fibrillation, and this thrombocytopenia. Okay, these are all not related to the
severity of the
yes.
It is given a Dallin Orbit book.
And pulmonary hypertension occurs in more of severe MS.
Yes, sir.
And you said you didn't have clinical evidence of RVH. What are the clinical evidence of, you said, RV predominance?
It's apical impulse shifted outwards, sir.
Okay.
Left parasternal heel and epigastric pulsation.
Epigastric pulsation, you have to quantify how it will be. It will be pulsated, felt in the tip or in the
tip of the fingers.
Okay. These are the clinical evidence of RVH. Any other evidence of a PAH? What are the clinical features of pulmonary hypertension?
Clinical features are breathlessness, palpitations,
exertional
signs of right heart.
Exertional dyspnea, exertional syncope.
Yes, sir.
Why it occurs, exertional syncope occurs in PAH?
Sir, exertional?
What? Syncope occurs in pulmonary hypertension.
It's due to the reduced blood flowing entering the left atrium, sir.
I mean, I didn't get it. It's reduced?
Reduced blood, cardiac preload to the left atrium, sir.
Why left atrium preload is reduced?
Due to the pulmonary artery, shrinkage of pulmonary arteries.
So, the pulmonary hypertension occurs, the pulmonary pressure is high. Okay. So,
yes, sir.
It acts as a fixed cardiac output. Even if the cardiac heart wants to increase the cardiac output, it may not increase the cardiac output because of pulmonary hypertension. It's sort of like a fixed cardiac output. So when you patient exerts, he may not increase the cardiac output. So the exertion syncope occurs. Okay,
Yes.
what you said is correct, partially correct. That is, since the cardiac output, pulmonary flow is reduced, your LA return is reduced. That's why you
Yes.
said the LA volume is reduced. But we have to say because of fixed cardiac output, secondary to increased pulmonary artery pressure.
Okay.
So
Okay.
the patient developed syncope-on exertion.
Okay. Okay.
I think I'm clear, or you should repeat?
Yes, sir. Yes, sir. Clear.
Clinical features of PPH.
Features loud and palpable second heart sound, sir.
Okay.
There may be a murmur.
Palpable and loud. Always palpation comes first and the auscultation comes next. Okay.
Okay.
Palpable and loud second out. So pulmonary component P2. Okay.
In addition to that, there's got a pulmonary vascular click. It indicates there's a pulmonary artery is dilated. Patient has got a pulmonary hypertension. Okay, and also the murmur of the pulmonary valve, then systolic murmur or PR murmur is again favors presence of pulmonary hypertension. And RVH again the favors pulmonary hypertension. Okay.
Okay.
Thank you.
Did you look for RVH? 8 parasternal
Yes,
heave was there?
No, sir. No parasternal. No parasternal heave in these patients.
The parasternal right ventricular, the parasternal heave should be always examined in a supine position. Otherwise, you will miss it. Okay. And use the which part of the hand will be used? Heel of the hand should be used. Firm pressure in the parasternal area and the patient in the supine position should be followed. Otherwise, you will miss the parasternal. Okay. Don't look for in the sitting posture and then say I know parasternal. Make the patient to lie down, supine position. Give a firm pressure with the heel of the hand parallel to the left sternal bottom. Okay.
Okay. Okay.
This is the way to identify the parasternal. Otherwise, you will miss it.
Okay.
Right. So now, what are the features favors severe mitral stenosis?
Narrow and long duration murmurs.
Okay. Again, pulmonary hypertension also it favors because it's always the significant pulmonary hypertension. MS only can cause pulmonary hypertension.
Yes, sir.
So this unlike AF, CVA and endocarditis, the pulmonary hypertension is directly proportional to the severity of the MS.
Yes.
Okay.
Yes.
Right. So what do you like to go for next?
Investigation.
Investigation. Okay. Which one you will prefer? You want suppose the examiner is asking you whether you want ECG or X-ray. So what will you ask? If you are suspecting a stenotic lesion, you opt for ECG first. Okay. If you are suspecting a regurgitant lesion, ask for X-ray first. That will give more information. In general, there may be some exception, but in general, the stenotic lesions, ECG will give the information as well as the stenotic lesion. The X-ray will give more information for the regurgitant lesion. Okay. So first, what's your preference? ECG or X-ray? ECG. Okay, you put ECG. Okay, go ahead. Go ahead. ECG. Yeah, you're suspecting a stenotic lesion, no? So we'll get the ECG first.
It's a 12-lead ECG, sir, showing a heart rate of around 60 per minute, sinus rhythm, and normal axis, P mitral present, sir.
Classical P mitral, do you see? The classical P mitral is camel hump appearance. The two peak in the mitral. What's the mitral look like a bifid? That's called a classical mitral P mitral. That means the camel hump appearance. two hump in the P wave, and the distance between the two hump will be 40 milliseconds. Okay.
Okay.
That's the classical textbook description of P matrix.
Okay.
Yes, right. I do agree. The P wave appears to the duration appears to be slightly long, but I won't say it's a classical P matrix.
P matrix. Okay. Q wave and ST elevation in the lead 2-3 AVF and V4 to V6.
Okay, very good. You have picked up nicely. There is a Q wave in the 2-3 AVF. Do you think it's a pathological or not?
How to say pathological Q wave?
Pathological Q wave.
It's a deep symmetrical.
Okay, so I'll teach you. See, you remember, right? This is where I teach for the students. Remember number 4. Okay.
Okay.
If the Q wave is more than 4 millimeter depth.
Okay.
If it is 40 milliseconds in duration.
Okay.
If it is 1/4 of R wave in the same complex, it is a pathological. I repeat again, 4 millimeter depth, 40 milliseconds duration, and 1/4 of R wave in the same complex. This is the criteria to say pathological. Okay. So now tell me whether it is a pathological Q wave or not.
It's not, sir.
Does it fulfill all the 3 points which I have told?
No, sir.
Certainly not. So need not give importance to the
Q waves.
Okay. It's not pathological.
Okay.
Is it clear?
Yes, sir. Yes, sir.
Yeah, you got a J point elevation, ST elevation. This is J point elevation. So J point elevation can have a early repulsion.
Early repulsion.
The range should not be taken as a pathological.
Pathological.
Right?
Yes, sir.
What other abnormality you see in the ECG?
Sir?
What other abnormalities do you notice in this ECG?
V1.
Look at the V1.
V1.
Yes, sir.
So now you don't see any tall, you don't see R wave, tall R wave in a V1 unless the patient has got RVH or right bundle large block. Here you see the duration is normal, whereas there is a reasonably good size of R wave is seen here. That means what does it indicate?
Pulmonary artery.
So right ventricular pressure is or pulmonary pressure is high.
Yes.
So by just count the number of this height of the R wave in V1 and multiply 5 by 5. This gives rise roughly the
pulmonary artery pressure.
Okay.
Yes.
So this again the ECG favors pulmonary presence of pulmonary artery hypertension. Normally you will see very small R wave in a V1. Here you see a prominent R wave that itself indicates patient has got a pulmonary hypertension. Okay.
Okay, sir.
Right. Why not it's an incomplete RBB? I say it's incomplete RBB. What's your this one? How you contract?
Axis normal.
Not an axis. Okay. It's a duration is less. Okay. To call it as a bundle branch block, you should have a more than 100 milliseconds. 100 to 120 milliseconds incomplete and more than 120 milliseconds is complete RBB. So again, if it is a right bundle branch block, you will have a S wave and V5, V6, which is not there. So it is the right ventricular hypertrophy or even this one, increased pulmonary artery pressure. Okay. It does not indicate this is not a right bundle branch block. Okay. One is RSR pattern is missing. Second is the duration is normal. Third is there is no S wave in V5, V6. So it is not RBB. Okay. So the examiner says why not it is RBB, should have this ready-made answer which I have told. These are 3 points you have to justify that it is not a RBB. Okay.
Okay, sir. Okay.
Right.
You know what is the type of, it's an old school
type of RVH. Yeah.
Type of RVH.
Yeah. Not sure, sir.
It's not.
There are 3 types: type A, type B, type C. Okay.
Okay.
Type A RVH is monophasic R wave or small Q and R wave.
Okay, sir.
Type B RVH is this, you will have an RSR pattern. Okay.
Okay, sir.
So monophasic R wave is seen in pulmonary stenosis, Whereas type B RVH is seen in the rheumatic heart disease. So type B, type C for this COPD. You will see in a respiratory disease. Okay.
Okay.
There are three types: type A, type B, type C. So type A is in a congenital pulmonary stenosis. Type B is rheumatic heart disease. Type C is in a respiratory disease.
Okay. Okay.
Okay.
Okay.
So with the ECG, how it adds to your diagnosis? Any extra point you got it?
Pulmonary artery pressure.
Yeah.
Hello.
Pulmonary hypertension is different with the ECG.
Yes.
Okay?
Yes, sir.
And indirectly it indicates a severe mitral stenosis. Fine. So moderate is not into picture now. Fine.
Yes, sir.
So, but you say as pulmonary hypertension, but you have only subtle clinical finding in your clinical examination. Do you have an explanation for that? Because only P2 loud, otherwise no other point to say as pulmonary hypertension. And the,
Yes.
okay, why you mean? Why you got a very subtle clinical finding of pulmonary hypertension, but electrocardiogram you got a very good RG forces.
Young females and
Fine. So females, some adipose tissues, you may not have. I mean, may not get all the findings of pulmonary hypertension sometimes. Okay.
yes, sir.
Okay, next. Fine. Good.
Can you go to X-ray? So, is there any cardiomegaly or not?
No cardiomegaly, sir.
No cardiomegaly.
Yes, sir. So there is a straightening of the left heart border, sir. Mitralization of the heart. And shadow on shadow is.
So the straightening and straightening indicates the LA appendage is dilated and MPA left main pulmonary artery is dilated. The shadow within the shadow indicates right left
dilatation of left atrium.
So the apex is a LV apex or RV apex?
It's LV apex.
Very good. It smoothly merges with the left dome of the diaphragm. When there is an angle between the dome of the diaphragm and the cardiac shadow, is obtuse, it is LV apex. If the angle is very narrow, acute angle indicates RV. This one, right, RV apex. Okay. Here, the cardiac shadow smoothly merges with the left dome of the diaphragm. The angle is obtuse, so it is a left LV apex. Okay. So the what other abnormality? One is that is straightening of the left heart border. Second is shadow within the shadow. What third abnormality you see in the X-ray? There is evidence of right atrial enlargement here, isn't it?
Yes, sir.
So how do you say right atrial is dilated?
From the spine to lateral right side heart border 5 centimeter distance.
Yeah, from the mid spine line to the outer border of the right cardiac shadow is more than 5 centimeters. Second is if it occupies more than 2 intercostal space, again it indicates atrial enlargement. So here both the atria are dilated. Where will you get both atria dilated in rheumatic heart disease?
Mitral stenosis.
Yeah, mitral stenosis.
Then
mitral regurgitations.
Mitral regurgitation caused only earlier dilatation. Okay, it's beyond the scope of your MD postgraduates. When the patient has got the atrial fibrillation, both the atria can get dilated. Okay. Now, of course, the patient now is in sinus rhythm. She might have had a paroxysmal atrial fibrillation every now and then. That can explain the dilatation of the right atrium as well as left atrium. One second thing, the patient has got a PAH with tricuspid regurgitation. Okay,
yes,
are also dilated along with the LE. Okay.
Okay.
See, these are the two explanations to say biatrial enlargement. Isn't it? Are you able to follow me?
Yes, sir. Yes, sir.
Right. Okay.
And rarely, if the patient has organic tricuspid disease, then also you can get it. Multivalve disease. Mitral,
Yes.
organic mitral and organic tricuspid valve, then you can.
That's the other possibility, right?
Okay. Okay.
What is organic and what is functional?
Organic is a disease per se in that parts. Primary disease.
It is not because of the pressure effect, because the mitral valve, tricuspid valve itself is involved in rheumatic disease. Then if it gets stenosed or regurgitation occurs, then it is called an organic. If it is the TR occurs secondary to the PA pressure, it is called functional TR.
Functional.
Fine.
Yes.
Fine, Pa. So how will you approach? So what is the next investigation you have to look for?
Echocardiography.
Okay, go ahead. So does it favor? So it's a parasternal longus view where the left atrium is grossly dilated. Okay.
Dilated. Yes.
And the thickening of the anterior leaflet and posterior leaflet. The posterior leaflet movement is resting. This is called the hallmark of rheumatic heart disease. Okay. So it's approved that patient has mitral stenosis. Play it again. Yeah, there is some mitral valve opening is narrowed down. All favors mitral stenosis.
Okay.
So the shadow, this was rightly pointed out. Patient has got a shadow within the shadow. It favors Lilly enlargement. Is confirmed in a echocardiogram.
Okay. Okay.
So how will you treat the patient?
Diuretics for pulmonary congestion, sir.
Very good.
Beta blockers.
What diuretic will loop diuretic or what type? So many diuretics are. Which will you prefer?
Loop diuretics.
Ideally, very good. So ideally, should choose the loop diuretic along with the potassium diuretic also because it can cause hypokalemia. Okay. Any other drug you want to look you?
Beta blockers, sir.
Wonderful, sir. Though patient is in a sinus rhythm, they have to keep the rate under control because this mitral stenosis is poorly tolerated. Bradycardia is poorly tolerated. Or tachycardia is poorly tolerated.
Sir.
Mitral stenosis. Which arrhythmia is tolerated well? So bradyarrhythmia is well tolerated or tachyarrhythmia is well tolerated?
Bradyarrhythmia is tolerated.
Very good. So mitral stenosis is get worsened when the heart rate goes up. Aortic regurgitation gets worsened when the heart rate comes down. You remember this, okay?
Okay, sir.
So aortic regurgitation will get worsened when the heart rate goes down. So bradycardia is overly tolerated by aortic regurgitation, whereas mitral stenosis is poorly tolerated with tachycardia. Okay.
Okay, sir.
Okay. So it's mandatory to keep the heart rate under control. Either with a beta blocker, or there is a digitalis. So which will you prefer? When will you choose beta blocker? When will you choose digitalis?
Beta blockers will control both the exertion and resting heart rate. Patient.
Digitalis.
Patient. Patient having tachyarrhythmia in a resting, sir.
Yeah. So digitalis preferably controls the resting heart rate, and this beta blocker will bring down the exertion, the tachycardia. Okay.
Okay.
So depend upon that, you can choose either one of this. Okay. Any other drug want to give her?
Rheumatic fever prophylaxis.
Very good. Rheumatic fever, because she is a young lady, 27-year-old lady. So ideally, at least up to 40 years you have to give rheumatic fever prophylaxis. Ideally, lifelong, but at least up to 40 years. Okay. So she needs to be given on this one rate reduction drug, diuretic, and rheumatic fever prophylaxis. Okay.
Okay, sir.
Injection or tablet?
Which is preferable?
Benzathine pencil injection.
Yeah, injection is preferred always. Okay.
How frequent?
Once in 3 weeks.
Why the 3 weeks, not 4 weeks?
There are a few countries gives once in 4 weeks, but we give only 3 weeks. Why it is so? Is my question clear?
Yes, sir. Yes.
Worldwide, there are few countries give advice once in a month, whereas we advise once in 21 days. Why this disparity between Indians and abroad people?
Not sure, sir.
Not sure. Okay, because of the climate condition, the metabolism is so fast in India, like our population. Okay, so it fastly get metabolized in the Indian scenario, whereas in a cold countries like abroad, the metabolism of the penicillin is very slow, so they can give once in a month, whereas we give once in 3 weeks.
Okay.
Sometimes we give once in 2 weeks also, rarely.
We give injection as a depot injection.
Yes, sir.
When IM injection. So it will release for 3 weeks. In temperate climates, cold climates, where vasoconstriction is the phenomenon, the release will be very late. In tropical country like India, where it's warm, the vasodilatation occurs, so easily wash out can occur. So we may not the report cannot long last. It lasts for only 3 weeks. Fine.
Okay, sir. Okay.
And the tablet form, you prefer tablet form?
Penicillin V, sir.
What is the difference and why it is inferior? So they have studied that the recurrence of rheumatic fever with injection is less compared to that of tablet. Tablet it is slightly more. So it's preferred to give injection form. The frequency is there, and that I think so by injection the frequency, relapse of rheumatic fever is less. By tablet form it's slightly more. So we prefer injection forms.
Okay.
Vinod, the patient did not give any history of rheumatic fever, but still be diagnosed as rheumatic fever, isn't it?
Yes, sir.
So what percentage of people will come out of the history of rheumatic fever in the past? Patient did not give any rheumatic fever. We did not find out any markers of rheumatic fever, but still we are diagnosing as a rheumatic fever. They are correct only.
Yes, sir.
Why did we say this rheumatic fever in spite of not being in the absence of rheumatic history and absence of rheumatic markers?
40% patient usually don't have a history of rheumatic fever.
Not 40%, so 1/3. See, remember, this is easy calculation. Remember 1/3. Most of the pharyngitis are due to viral. Only 1/3 is due to bacteria. Of that 1/3, only 1/3 will go for a rheumatic fever. Of that, only 1/3 will have a rheumatic heart disease. Okay, so that's only 1/3 people will recollect the past history of the rheumatic fever. Okay, that's the reason. And cardiac echo, I told you, there are few features: thickening of the AML, PML, and recession of the restricted movement of the post-rheumatic blood is hallmark of rheumatic heart disease.
Yes, sir.
Correct. Okay, we know the presentation is very excellent. Chronologically, you gave the presenting complaints in chronological order. You have not missed out any history in the presenting illness or past history. Your approach is very logic. You are able to answer more than 90% of the questions, except 1 or 2 findings which you have missed out. Otherwise, I don't find any discrepancy or lacunae in your presentation. If you go with this, I think you will kind of easily go to get through your exam. All the best for your exam. Let's get feedback from Dr. Tamilarasu.
Vinod, excellent presentation, good flow, and mature presentation. And I think you have answered if I given 100, I'll give 95%. Fine. So it's fantastically a good presentation. I admire your presentation, and so all the best. Do well in the exam.
Dr. Ramasamy, sir, can we ask him 1 or 2 questions about the valve replacement and the artificial valves? 1 or 2 questions about that.
Fine,
1 or 2 questions before winding up.
Yeah, Vinod.
Sir?
The patient what type of the patient has severe stenosis now? What intervention would you like to advise for this patient?
Balloon mitral valvuloplasty.
Oh, excellent. Because the reason is, he's a young lady, he's taking treatment for infertility, so she like to have children in the future. So replacing the valve is not an ideal thing. So I prefer the patient should be submitted for the balloon mitral valvuloplasty. Okay. Suppose if the valve is not suitable, if the patient wants to, so you have by force we need to replace the valve. What type of valve will you prefer?
Mechanical valve, sir.
No, see, anybody is in the family way should prefer bioprosthetic valve, because only first 3 months of post-operative period need to take an anticoagulation because of the endothelialization. Thereafter, you can manage with only single antiplatelet. Since the patient, this lady is already waiting to have a child, I prefer better to give her a bioprosthetic valve. Once the family have a children, then subsequently if bioprosthetic valve goes for wear and tear, we can replace mechanical valve. Okay, because the anticoagulation related complication is more. They see the whatever if she become pregnant, it's going to be precise child for her, isn't it? We can't afford to lose.
Yes.
So bioprosthetic valve is preferable rather than a mechanical valve. As Tamil also.
I think what Sir said is correct. We discuss with the patient, and when we give a bioprosthetic valve, the reintervention after 10 years, 12 years, reintervention they may require a reintervention. Discuss the what is the hazard of giving anticoagulation and becoming pregnant? What is it called?
Congenital malformations.
What is called?
What it, sir?
What is it called?
Warfarin.
Embryopathy. What are the defects you will expect?
Congenital contractile syndrome.
Oh. So when the patient is exposed for an anticoagulation the first trimester, the chance of having the baby with defects, particularly the facial cleft palate, these are all defects called embryopathy can occur. So we tend to avoid an exposure of anticoagulation the first trimester. Second trimester, we used to give anticoagulation because your organ might have already well formed. And third trimester, before delivery, we again switch over to heparin. And now the recent recommendation says check the dose of warfarin. If it's less than 5 mg or more than 5 mg. If it's more than 5 mg, then
you have to change the anticoagulants to
less than 5 mg.
No need to change.
No need to change, but the chance still is. We have to discuss again. We have to discuss with the patient, because even the small percentage, the patient should not sue you. Okay.
Yes.
You have any idea about the valve names? You might have seen a lot of patients with prosthetic valves in the ward. I used to tell the morphology of ball and cage, bileaflet, and tilting disc.
Yes.
It's always better to say all these instead of name the valves. You can say these 3 types of valves are there. Okay.
Okay.
I think you don't read about this topic, because it's also one of the short notes commonly expected. The mechanical valves, bioprosthetic valves, what other tissues can be used for preparing these valves? All those things are commonly asked questions. Similarly, you should go and read about this fetal alcohol, fetal phenytoin, warfarin, and rubella infections. When you're going to read about this type of cardiac disease, a bit familiar with it, may be asked in the short notes also. Okay. So whenever you're going to come across a patient with this valvular disease, definitely if the discussion is going in a smooth manner, they might land up with definitely valve replacement interventions also. 1 or 2 points they might ask you to give more marks. In that case, you should be familiar, and the flow should be the same flow. You should not get stopped because the level is going to be slightly higher level, which is you should be familiar with. They're not going to ask you about the techniques. They're going to ask you about the outline about the points about the valves and the indications and contraindications. Only DM only you're going to ask about all the techniques. Whereas we will not be asked about those techniques which is beyond our scope, right? Go and read about the last point of what all the discussions happened. Go and read about this topic also.
As far as the valve is concerned, valve can be classified into 2. One is mechanical valve, as a bioprosthetic valve. Bioprosthetic valve, again, it's maybe a homograft or retrograft. Homograft is sometimes the pulmonary valve is taken and replaced in the aortic valve, the same patient. The heterograft is harvested from the bovine and pork and the bovine valve and porcine valve. Coming to the mechanical valve, as Tamil said, there are different type of valve. Tilting disc is called popularly called TTK Chitra. Then ball and cage valve is ball and cage valve. Then single bileaflet valve. Okay.
Okay.
Why I am telling you about the TTK Chitra valve is made in India from the Chitra Institute of Trivandrum. As Saran rightly pointed out, they may expect you to know about something about the valve because we are mostly using the TTK Chitra valve because it's cheap and best. It's made in our country. That is from our neighboring state. So I think as Saravanan rightly pointed out, it's better to have some sound knowledge. When the patient, when the examiner want to give a more mark, they may expect you to have some idea about it. Okay.
Okay.
Right. So TTK Chitra, remember Chitra. TTK Chitra is from Chitra Institute, Trivandrum, Kerala.
Okay.
I think good job, Dr. Vinod Pandey. Go and read a book and recollect all the questions raised by the faculties, note it down, and start preparing still more finer points from the clear cut from the textbooks also, which is not addressed by the faculties. Try to anticipate those questions in the examination, so that you better answer the questions which is not asked now. Okay. Recollect and write it down the questions and try to find out the answers from the standard textbooks also. Okay.
Okay.
Yeah. Anything else that Tamil Nadu say or Dr. Ramasamy sir?
Thank you. I think you can guide. He has done a reasonably good job. We wish him all the best. Hope we.
Thank you. Thank you, Dr. Tamil Nadu sir and Dr. Ramasamy sir for this wonderful presentation. And appreciate Vinod Pandey for a wonderful presentation. We'll meet next week with another case of discussion. Thank you and good night to all of you.
Thank you. Good night.
Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you.